Hello, this is Dr. Grant Cooper from Princeton Spine and Joint Center. In today's video, I'm going to tell you everything you need to know about shoulder pain. I'm going to do it over the next 15 minutes or so, give or take. We'll see exactly how long it takes. Specifically, I'm going to cover what causes shoulder pain, how you know what's causing your shoulder pain, and what you can do to get it better. It's a lot to discuss, so let's get started. First, let's get into what causes shoulder pain in most cases. Now, there are four main causes of shoulder pain. The most common is pain from the rotator cuff tendon, which can be referred to most commonly as impingement syndrome, or rotator cuff tendonitis, or subacromial bursitis. As we'll see in a moment, these are all basically the same thing. Now, let me explain. The rotator cuff muscles are responsible for anchoring the shoulder in place. That is, they stabilize and they protect the shoulder joint. There are four different specific muscles and their tendons that make up the rotator cuff. Remember that a tendon is what attaches a muscle to a bone, or that's what a tendon is. In impingement syndrome, in overhead activity, in particular, the rotator cuff tendon becomes impinged between a bone and a ligament. So here's the shoulder, here's the rotator cuff tendon, and as you move your shoulder up, it can impinge underneath this ligament. Now, this can also happen with other movements such as reaching behind the back, but it's most common with overhead movements. And this impingement can lead to irritation of the rotator cuff. So impingement syndrome is really one of the causes of rotator cuff tendonitis. For all intents and purposes, they can be treated as the same thing. Additionally, beneath the tendon, there lies the subacromial bursa, and the rotator cuff tendon can rub against this bursa, which can lead to friction and irritation that leads to subacromial bursitis. Subacromial bursitis and rotator cuff tendonitis present identically clinically. They have the same biomechanical causes and are treated ostensibly the same way. So we can consider all of those things together, along with impingement syndrome, as part of the same syndrome. Now, impingement of the rotator cuff can also lead to partial tearing of the rotator cuff. And in fact, partial tears in the rotator cuff are actually very common even in people without symptoms. And that's an important point. In fact, more than 50% of people over 60 have partial thickness rotator cuff tears and have no symptoms. But when the tear becomes inflamed, then for sure it can become painful. Rotator cuff pain is generally worse with overhead activity and reaching behind the back, as we said. And it often hurts also when you roll over in bed onto the shoulder. A common thing that people with rotator cuff pain will say, in fact, is that they were lying in bed, they rolled over, and their shoulder became painful and actually woke them up out of sleep. Another common cause of shoulder pain is a labral tear. The shoulder is a ball and socket joint. The socket has a lining called the labrum. The labrum is a type of cartilage that helps cushion and stabilize the shoulder joint. The most common type of injury to the labrum is called a slap tear. But generally, labrum tears present as deep, aching shoulder pain that's worse with overhead activities and also with activities that involve reaching across your body. Also, sometimes with labral tears, the shoulder will pop or click when the shoulder is moving, and the shoulder may actually feel weak with activities like trying to lift things up. Now, importantly, people can have labral tears and have no symptoms. So therefore, the presence of a labral tear on an MRI doesn't mean that this is necessarily causing the patient's pain, just like the presence of a rotator cuff tear doesn't necessarily mean that that's what's causing a person's pain, right? So the MRI findings are certainly of value and they add to the overall clinical picture, but they're still just a piece of the picture, not the whole picture. Now, biceps tendonitis is another common cause of shoulder pain. The long head of the biceps runs up through the bicipital groove in the humerus and attaches to the top of the glenoid or shoulder socket. Sometimes this tendon can become inflamed. Biceps tendonitis is most common with overuse injuries in sports that require repetitive overhead activities like swimming, tennis, baseball. Biceps tendonitis generally presents with pain in the front of the shoulder. The tendon is generally very painful or tender to palpation. Now, another less common but still important to mention cause of shoulder pain is shoulder osteoarthritis. Osteoarthritis is a much bigger problem for weight-bearing joints like the hip or the knee, but it can still be a problem in the shoulder either in the glenohumeral joint or in the acromioclavicular joint, also known as the AC joint, where the collarbone meets the acromion. Over here. People with symptomatic shoulder OA usually are over 50, and they have a history usually of a shoulder injury or injuries that then set the arthritic process in motion. Though sometimes there's no known reason for the arthritis starting, presumably something genetic, but pain and reduced range of motion are hallmarks of shoulder osteoarthritis causing symptoms. Now, a couple other notes about shoulder pain. One thing is that whenever the shoulder hurts, you need to consider whether or not the neck is involved and make sure that that's something that you're aware of, because the neck can be involved in shoulder pain in two different ways. One is that the pain in the shoulder can be completely referred from the neck. That is, there's nothing wrong with the shoulder, and the pain that's felt there is coming directly from the neck. So for example, this could be from a pinched nerve in the neck or an arthritic facet joint in the neck that's simply referring pain into the shoulder, and that can be the cause of the pain. So in these instances, you move the shoulder around and it doesn't hurt, right? Overhead, behind the back, doesn't matter. However, moving the neck around and specifically turning your head to the side of the pain and then extending the neck backwards can reproduce the shoulder pain, and that's a very big clue that the neck is actually causing the shoulder pain. Now, the neck can also be involved with shoulder pain if the nerves that innervate the rotator cuff muscles are inflamed and they're not firing as they should be. If this happens, then the rotator cuff muscles don't get their signals efficiently, and this can lead them to not protecting the shoulder the way that they should, and this predisposes the shoulder to then this secondary musculoskeletal problem, right, of developing a shoulder pathology. Now, if this is what's going on, if this is present, it's important to recognize the neck's involvement, because you'll need to make the neck better in addition to the shoulder, or else when you make the shoulder better, but you've left the nerves in the neck to still be inflamed, then you've left the same underlying conditions that can then lead to the shoulder becoming problematic again, just like it did in the first place, right? Namely, if the rotator cuff muscles aren't getting the signals at the right time from the nerves in the neck, then the shoulder is still left unprotected. And the last note before we shift gears to the treatments for shoulder problem is that any problem with the shoulder predisposes to the potential of that person to develop something called adhesive capsulitis or frozen shoulder. A frozen shoulder is a problem where the capsular fibers that are typically smooth become inflamed, thick, and stiff. And basically, they start to freeze, leading to a marked loss of motion in the shoulder, hence frozen shoulder. In frozen shoulder, usually there's an initial painful period where the fibers are inflamed and they start to freeze. Now, this generally lasts several weeks, but it can last up to potentially several months. And then after that, there's a frozen period where the pain leaves, but the stiffness remains, and this can last for 4 to 6 months if untreated. And finally, the shoulder usually thaws over time, but this can take a couple of years to regain full function, and full function is not always regained. Now, other factors that predispose to developing a frozen shoulder include diabetes and thyroid problems, and this can be either too hyperthyroid or hypothyroid, too high or too little thyroid. The sooner an underlying pathology in the shoulder is addressed and full motion is restored, the less likely it is that someone will develop a frozen shoulder. If a frozen shoulder does begin to develop, then the sooner it's addressed directly, the better. Okay, let's shift gears now and talk about how we treat these different shoulder conditions. The hallmark of all of these problems that cause pain in the shoulder, whether it's rotator cuff tendonitis or a biceps tendonitis or a labral tear or osteoarthritis or a rotator cuff tear, is inflammation. You see, even a partial tear of the rotator cuff, the pain only comes if there's inflammation as a response to that tear. Remember, 50% of people over 60 have partial thickness rotator cuff tears and have no symptoms. So inflammation is a protein response, but the best way to think about it is that it's like a fire. And there are two ways that you can put out a fire. One is you clear away all the fodder, right? You move away the fodder, you let the fire die down. The other way is to use a fire hose. But when it comes to moving away the fodder, the common theme with all of the shoulder problems that we've discussed is therapeutic exercises. That is, stretching and strengthening the right muscles in and around the shoulder in order to support the shoulder and unload it in order to allow the shoulder to rest and to heal. Now, in general, this means safely stretching and strengthening the rotator cuff muscles and, importantly, strengthening the scapular stabilizing muscles. Recall that the shoulder is a ball and socket joint, and that joint is protected primarily by the rotator cuff muscles. However, and this is a big however, the entire joint and scapula, this is the scapula, is stabilized by being anchored to the spine over here. There are muscles that attach it to the spine primarily by the rhomboids. If the scapula and therefore the shoulder itself isn't stable, then no matter how strong the rotator cuff muscles are, they aren't going to find much success in protecting the shoulder because they aren't on firm footing, right? If the foundation is wobbly, it doesn't matter what the house is made of or how strong it is. You need a strong footing. So with your exercises, you need to make sure to pay attention to and also strengthen the scapular stabilizing muscles as much as you do the rotator cuff muscles. You can check out the best exercises for shoulder pain in our video that's appropriately titled The Best Exercises for Shoulder Pain. Now, sometimes you clear away the fodder, but the fire keeps on burning. Or there's so much pain that you really can't do the exercises. Either you can't do them correctly or you just can't do them at all because of the pain. And for all of these instances, you may have to take a fire hose and put the fire out with that. Now, for all shoulder issues, but particularly for biceps tendonitis, using ice and topical nonsteroidal anti-inflammatory drugs, also known as NSAIDs, can be particularly effective. Topical NSAIDs that you could find in a store, they would include like topical diclofenac or Voltaren gel. Basically, these are like topical Advil or topical Aleve, and they come in a gel or a cream. The reason these topical NSAIDs and ice work the best for biceps tendonitis is that the biceps tendon is so close to the surface of the skin, particularly as it passes through the bicipital groove in the humerus. So the anti-inflammatory medication and the cold from the ice can penetrate directly through the skin and to the problem area itself. Rotator cuff tendonitis is also a good target for these modalities. You can certainly use ice and topical NSAIDs for a labral tear or shoulder osteoarthritis, but those are intra-articular problems, so they're difficult for cold or a topical medication to actually penetrate into because there's more soft tissue that the medication or the cold has to go through. The exception to this would be AC joint osteoarthritis, because this problem is also, it's so close to the surface of the skin that the topicals and the ice have a chance to penetrate to the source of the problem. In physical therapy, in addition to helping teach therapeutic exercises, therapists can use their passive modalities, such as ultrasound and soft tissue mobilization, massage, to help with the inflammation. But the most effective way to deliver anti-inflammatory medication to the site of inflammation, that is the most effective fire hose that we have, is going to be an ultrasound-guided injection of anti-inflammatory medication where we can put the medication directly at the site of inflammation, whether that's into the glenohumeral joint or the rotator cuff tendon sheath or biceps tendon sheath. That's going to be the most effective way. Now, the most common medication that's used in injection is the steroid. It's commonly called a cortisone shot, but the medication or type of steroid that's actually used is typically celestone or dexamethasone or Kenalog. It's very important to use ultrasound guidance for any shoulder injection so that, one, the medication is put into the place that you mean to put it into, and two, in the case of a tendon, that the medication isn't accidentally injected into the tendon itself, which would not be good for the tendon. You want, with a tendon sheath injection, that the medication is injected into the tendon sheath, not the tendon fibers itself. And again, using ultrasound guidance is the way to make sure that this is done correctly and done safely. So with all that said, steroids can weaken tendons over time, even when they're injected correctly. So you have to be careful when you're considering injecting around tendon sheaths, and in particular when considering repeat injections. Most doctors, if they're considering injecting around a tendon sheath, they'll try to limit that to 2 to 3 injections in a year, each one spaced out by at least a month. Another option is you can inject something called Toradol. Toradol is an NSAID. It has the advantage of being not a steroid, and so it won't weaken a tendon, but it has the disadvantage of not being as strong of an anti-inflammatory as a steroid. Still, for tendon issues, particularly in young athletes, The use of toradol injections is gaining some popularity because of their safety profile, and they still have some efficacy. In general, no matter what anti-inflammatory you inject, if you inject, you need to realize that what you're seeking to accomplish with your injection is to take away the inflammation that's causing the pain. Importantly, when this works, you aren't masking pain, right? You aren't injecting lidocaine. You're not putting in an anesthetic. You're effectively taking away the inflammation. But you're also not changing the biomechanics that led to the pain in the first place. So it's important that when injections are used for any of these shoulder issues, that they're used as more of a window of opportunity to allow the patient to learn and implement a therapeutic exercise regimen to start shifting the biomechanics to move away the fodder so that as the medication slowly wears off, the inflammatory fire doesn't return. And used together, this can be a very effective combination. Now, for shoulder osteoarthritis and for labral tears, another option is to inject viscosupplementation into the glenohumeral joint. Viscosupplementation is basically like injecting joint fluid, and this can help to bathe and to lubricate and nourish the joint. This medication generally lasts for around 6 months and should also be combined with therapeutic exercises. Viscosupplementation is most commonly used for knee osteoarthritis, where its use is approved and covered by insurance companies. Shoulder osteoarthritis is much less common, and using viscosupplementation for shoulder osteoarthritis or for labral tears is generally not a covered expense by almost any insurance company, and so cost is sometimes an issue with this treatment. Now, another therapeutic approach for shoulder issues is by using regenerative medicine techniques. Regenerative medicine, it's an exciting and evolving field that essentially seeks to stimulate the body to ultimately heal itself. So these regenerative techniques include PRP, which stands for platelet-rich plasma. This is a procedure where you aspirate the patient's blood, you use a centrifuge to spin down the platelets, and then you inject them back into the pathologic site where they stimulate a release of growth factors that ideally will lead the body to use its own innate reparative capacities to heal itself. And there are other regenerative techniques like prolotherapy, amniotic fluid, bone marrow aspirate, and other approaches. They're all, again, they're seeking to help the body stimulate its own innate healing mechanisms. Unfortunately, none of these regenerative medicine techniques have enough confirmatory research behind them to get insurance to cover them. So as a result, insurance almost never covers any of these procedures, which is unfortunate. So personally, if they were a covered procedure, I would often be recommending PRP in particular for rotator cuff and biceps tendon issues, particularly in lieu of steroid injections. But regenerative medicine techniques can certainly be quite expensive. They usually run between anywhere from $750 to $3,000 or more, depending on the particular doctor and particular regenerative technique being considered. So this is obviously something that can be prohibitively expensive for many, if not most patients. Still, these are options that should be considered and at least discussed with your doctor, particularly if surgery is being considered. So finally, there are surgical approaches for each of the more common shoulder pathologies. For rotator cuff tendinopathies and for partial rotator cuff tears, arthroscopic surgery can be used to debride and repair the tendon. This is also true with biceps tendonitis and partial tears of the biceps tendon as well. Labral tears can likewise be repaired. For shoulder osteoarthritis, arthroscopic surgery can clean out mild and moderate cases. And for more severe cases, shoulder replacement surgery is an option. Now, lastly, there's a debate about when and if to surgically repair partial and or full thickness rotator cuff tears in patients who have minimal or no symptoms. On the pro side of doing the surgery is that the sooner you repair a torn tendon, the easier the surgery is going to be. For partial tears, early surgery will help them prevent them from becoming full tears. And for full tears, if you leave them untreated, the tendon can retract over time, and then surgery later in life may be more difficult or impossible. Now, then again, recall that many people walk around with no symptoms from rotator cuff tears. So would you want to find all those people with no shoulder pain but rotator cuff tears and operate on all of them? I don't think so. Now, there is widespread agreement that if you have a full thickness rotator cuff tear, and if you're a professional baseball pitcher where, a 100-mile-per-hour fastball is critically important and a 90-mile-per-hour fastball just isn't going to cut it, then you're going to need that surgery because you're never going to have full strength, full strength in your shoulder without an intact rotator cuff. But that said, if you're an amateur athlete or you're just a regular person where an 80-mile-per-hour fastball is just fine, or probably better to say that if you're a normal person where normal everyday strength is just fine, then you may be able to achieve that through strengthening your compensatory muscles, and you might not need to ever repair the tendon, and you can still do all of your activities of daily living, play recreational sports, and you'll never even notice the strength deficit. So if you're not a pro athlete and pain is the only issue that you really care about, then you may be able to make yourself pain-free without ever surgically repairing the tendon. So personally, I can say I have plenty of patients with partial and full thickness rotator cuff tears that initially presented with pain, and I treated them with either injections or therapy or a combination of both of those things, and they've been asymptomatic for over a decade. And I have plenty of colleagues that would report the exact same thing. But there is an argument against this conservative approach for rotator cuff tears. And that's if you have a patient with a full thickness tear, let's say, who is doing great with conservative care, right? You get them pain-free. But then let's say 10 years later, that same person develops bad pain. And now maybe the conservative care is not working for whatever reason. But surgery might not be an option anymore because the tendon may have fully retracted. Or another instance is, what if you have a patient with a partial tear who's doing great with conservative care, but then years later they're playing their sport and they develop a full thickness tear that's now harder to treat. So these are all things that need to be carefully discussed between the patient and the doctor, because the truth is that with this, there's no one perfect solution. Each treatment approach is going to carry benefits and drawbacks. So personally, what I'll say is that knowing how many asymptomatic tears in the rotator cuff exist in the general population, I tend to lean towards conservative care for my patients who aren't professional athletes and who are doing great clinically with conservative care. But I think it's always important to have this discussion to make sure that the patient understands the benefits and the drawbacks of each particular approach, because each patient is going to be different and deserve a personalized approach to how they want to go about treating their shoulder. I hope you found this video on shoulder pain helpful. I hope you've learned something from it. If you have, please remember to like the video and subscribe to our channel and let a friend know to do the same. If you have any questions you would like for me to answer in a future video, then you can reach me at drcooper@princetonsjc.com. You can leave me a question or a comment, or feel free to leave a question or a comment in the comment section here. Thank you very much.